Hi, today we are going to discuss about the following topics. What are the topics that we are going to discuss about? So one. So what are all the topics that we are going to discuss about? One is neonatal cholestasis. Okay, first topic is neonatal cholestasis. You all know that a newborn is prone for jaundice. Jaundice in newborn can be physiological or pathological. Jaundice in newborn can be physiological jaundice or you can have pathological jaundice. Physiological jaundice. So what is mean by physiological jaundice? Physiological jaundice usually occurs because of increased RBC number but reduced lifespan. So more and more RBC will undergo hemolysis per day. As a result of which there will be a high bilirubin load. There will be a high bilirubin load. Okay, the physiological jaundice usually occurs after day 1 and it rarely lasts for more than 14 days. So it lasts less than 14 days. It never involves palms and soles. Never involves palms and soles. Okay, very rarely crosses more than 14 days. This is physiological jaundice. What is pathological jaundice? What is pathological jaundice? Pathological jaundice is a jaundice that appears on day 1, usually RH hemolysis. Jaundice that crosses 14 days. Jaundice in which direct bilirubin is more than 20%. Pathological jaundice, more than 20% of total bilirubin. Bilirubin. So jaundice on J1, jaundice lasting for more than 14 days. Direct bilirubin is more than 20% of total bilirubin. And jaundice that involves palms and soles. This is pathological jaundice. Pathological jaundice can be due to RH hemolysis, RH incompatibility. It can be due to ABO incompatibility. It can be due to ABO incompatibility. Okay, so one is direct bilirubin, more than 20% of total bilirubin, yellowish discoloration involving palms and soles. So the causes are RH hemolysis, ABO incompatibility, G6PD deficiency, even hereditary spherocytosis can present with pathological jaundice. Now let's come to neonatal cholestasis. Now let's come to neonatal cholestasis. So what is mean by neonatal cholestasis? Point number 1. Jaundice that crosses more than 14 days and your direct bilirubin more than 5 milligram per deciliter or direct bilirubin more than 20% of total bilirubin. Direct bilirubin more than 20% of total bilirubin. So this is the proper definition for a neonatal cholestasis. And in fact, whenever you have neonatal cholestasis, you can have Two classifications. One is whether it is a well baby or it is a sick baby. Well baby means usually the hepatocytes are normal. Hepatocytes are normal. So the synthetic function is normal. Well baby. So what are all the conditions that can cause neonatal cholestasis, and it lasts for more than 2 weeks along with direct bilirubin, but child not that sick? Very simple. One is extra hepatic biliary atresia. Second one is choledochal cyst. So this is with respect to well baby. When it happens in a sick baby, when the child is sick, so usually it can be metabolic liver disease. Metabolic liver disease. What are all the metabolic liver disease? Or it can be due to infections. What are all the metabolic liver disease that can present in a newborn as neonatal cholestasis? One, galactosemia. Second one is tyrosinemia. So one is galactosemia, second one is tyrosinemia, third one is also you can have neonatal iron storage disorder. Neonatal iron storage disorder, which is nothing but hereditary hemochromatosis, or it can be due to infections, particularly herpes. In all these conditions, the child is very sick. Child is very sick and liver hepatocytes are damaged. Hepatocytes are damaged. That's why the child is sick. So what are all the investigations you can do? So what are all the investigations? What are all the investigations you can do? One, in ultrasound, you can have triangular cord sign. Triangular cord sign. That is suggestive of what? Atretic extrahepatic biliary radicals. So it is a feature of extrahepatic biliary atresia. Or in ultrasound, you can see choledochal cyst. Cyst. This is with respect to ultrasound. Other investigations. Galactosemia. So what is the investigation that can be taken for galactosemia? What is the simple investigation that can be taken for galactosemia? Urine for non glucose reducing substances. Suggestive of galactosemia. What is the investigation for tyrosinemia? The investigation for tyrosinemia is simple investigation is raised alpha fetoprotein or urine N succinyl acetone. Okay, for herpes, you can do either serology or else you can do PCR for herpes. For neonatal iron storage disorder, you can do serum ferritin. You can do serum ferritin. So these are all the sum of the investigations. And remember, in biopsy, they will ask you, what is the biopsy finding in extrahepatic biliary atresia? In extrahepatic biliary atresia, the biopsy finding is proliferation of bile duct radicals. Whereas in case of neonatal hepatitis, Whereas in case of neonatal hepatitis, the finding is giant cell formation, and because of the destruction of hepatocytes, you have architectural distortion. Architectural distortion. Okay, you have architectural distortion. So this is, and then what are all the other causes that can cause neonatal cholestasis? What are all the other causes? Other causes of neonatal cholestasis are, one is cystic fibrosis. Cystic fibrosis can cause neonatal cholestasis. So this is about neonatal cholestasis. So what are all the things you need to know? Neonatal cholestasis means your indirect bilirubin is more compared to direct bilirubin. And as I told you already, physiological jaundice less than 1 day never occurs. Usually occurs between second day to second week. And it is usually indirect hyperbilirubinemia. Can be due to breast milk jaundice. It can be due to breast milk jaundice in which pregnanidiol inhibits the conjugation of bilirubin, or breastfeeding jaundice which is due to low breastfeeding as a result of increased transition time in the intestine leading to enterohepatic circulation, that is breastfeeding jaundice. Pathological jaundice, any bilirubin, okay, any bilirubin, direct bilirubin, 20% of the total bilirubin, 20% of the total bilirubin, and involving palms and soles, one produces chronic stress, are all direct hyperbilirubinemia or pathological jaundice. And remember, in extrahepatic biliary atresia, so apart from this decide, the other points that we need to know are are, so what does it mean? Present in extrahepatic biliary atresia, because of absence of bile, staining of the stool, it leads to pale stools. Pale stools. Usually pale stools is suggestive of extrahepatic biliary atresia, but it can be, at times it can be due to some staining. So usually you need to cut the stool and see whether the inner core part of the stool is yellow or not. Okay. And then presence of, but absence of pale stools doesn't confirm, but presence of pale stools. Okay. Presence of normal stools, presence of normal colored stool literally rules out extrahepatic biliary atresia. Normal stool. Okay, right. So as I told you already, in any case of neonatal cholestasis, well baby means choledochal cyst or extrahepatic biliary atresia. Okay, other causes are cystic fibrosis or intrahepatic dilatation of bile duct, which can occur in Caroli's disease. And one more other causes are torch infection, I told you, herpes, Niemann-Pick's disease C, inborn error of metabolism apart from galactosemia, thyroxinemia, hereditary galactosemia, thyroxinemia. You also need to know Niemann-Pick's disease because of excess cholesterol storage. What is PFIC? Progressive familial intrahepatic cholestasis. Alpha 1 antitrypsin deficiency is not common in India. Not common in India, right? Sick looking, as I told you, galactosemia, thyroxemia, neonatal hemochromatosis, herpes. What are all the clues for neonatal cholestasis? What are all the clues for neonatal cholestasis? For all torch infection, the child will have rash, microcephaly, hepatosplenomegaly, petechiae purpurae. Galactosemia means E. coli sepsis is galactosemia, and Alagille syndrome, butterfly vertebra, triangular faces, and Niemann-Pick's disease, you can have cherry red spot. Ultrasound, as I told you already, you can see choledochal cyst, triangular cot sign in case of extrahepatic biliary atresia, dilatation of intrahepatic biliary radical. Dilatation of intrahepatic biliary radical occurs in coronary disease. And you must be knowing that what is called as HIDA scan. HIDA scan means the presence of the dye HIDA into the gallbladder, literally Okay, rules out extrahepatic biliary atresia. It has got a more negative predictive value that like CRP. So if EDA scan is normal, it rules out extrahepatic biliary atresia, but it doesn't confirm. It can be due to other diseases also, right? So what is the treatment? Bile duct proliferation, liver biopsy, as I told you. Neonatal hepatitis is characterized by architectural distortion. So treatment. So what is the treatment for neonatal cholestasis? You need to give fat soluble vitamins A, D, E, K 5 times. Fat soluble vitamin 5 times. It was discussed yesterday in the topic under cystic fibrosis. Fat soluble vitamin 5 times, and then water soluble vitamins B, C 2 times the normal recommended daily allowance. Recommended daily allowance. Okay. And then what is the treatment for galactosemia, lactose free diet? For extrahepatic biliary atresia, the treatment of choice is liver transplantation. But interim procedure, Kasai procedure can be done within 60 days. Acyclovir for herpes, IVIG for neonatal hemochromatosis. So these are all the points that you need to know with respect to neonatal cholestasis. Okay, now let's talk about Wilson's disease. So what is Wilson's disease? So this is about neonatal cholestasis. Neonatal cholestasis means a small revision, bilirubin, hyperbilirubinemia lasting for more than 2 weeks. Direct bilirubin more than 20% of the total bilirubin. Will baby, sick baby, will baby causes, sick baby causes, investigation, treatment, that's all. Okay, right. Now let's talk about Wilson's disease. So what is Wilson's disease? It is an autosomal recessive disease. So unless otherwise proved, you will have a consanguineous marriage. Third point, what is the mutation? ATP7B is the mutation. What happens in Wilson's disease? Your ceruloplasmin that binds the copper will be low. As a result of which, free copper will be rich in, will be there in iron in the serum, blood. This free copper in turn causes RBC hemolysis. In turn causes RBC hemolysis. So it is Coombs negative hemolytic anemia, direct copper mediated damage. 6. 7. With respect to liver, any kind of manifestation can come. One is acute hepatitis. Second one is chronic hepatitis. You can have asymptomatic hepatomegaly. You can have transaminitis. You can have transaminitis. Okay. Asymptomatic transaminitis. You can have cirrhosis with portal hypertension, etc. Any kind of, and you can have acute fulminant hepatic failure. Acute fulminant hepatic failure. You can have 7. Okay. With respect to liver, right? Acute chronic like liver. So what are all the, and then it can directly act on the basal ganglia and cortex, leading to involuntary movements. Leading to involuntary movements. Any child with involuntary movements, serum ceruloplasmin should be done. Involuntary movements. And it can cause neuroregression in a school going child. Neuroregression in school going child. Neuroregression in a school going child. Which one? Copper, direct copper mediated damage. Okay, 9. And what else you can have? The copper. Okay, and it can also cause proximal renal tubular acidosis, that is Fanconi. Okay, proximal renal tubular acidosis, otherwise Fanconi syndrome. Okay, Fanconi. So what are all the other manifestation Fanconi? So these are all the manifestation. What are also RBC, copper, neuroregression, liver, and then you can have, what is that? KF ring, because of the deposition of copper. So what are all the investigations that you need to do for Wilson's disease? What are all the investigations that you need to do for Wilson's disease? 1. Serum copper, no, you should not done, unreliable. So what you need to do? Urine copper, yes. Urine copper, yes. So urine copper of more than 100 microgram per day after penicillamine. And then liver copper. And then you have liver. Liver copper is more than 250 microgram per gram of dry weight of liver. So urine copper, liver copper, and then you can do ATP 7B mutation. So these are all the investigation. So what is the treatment of choice for Wilson's disease? What is the treatment of choice for Wilson? 1. Chelatas, penicillamine. Copper. Second one is trientine. Penicillamine is widely available but not trientine. So trientine is preferable compared to penicillamine. But penicillamine availability is more and it is cheap. Third, and can you have one more drug called ammonium tetrathioamolybdate. Ammonium tetrathioamolybdate. It is used in neurovils. It is used in neurovils. Which one? Ammonium tetrathioamolybdate. Used in neurovils. Okay, is used in neurovils, right? And then zinc. Zinc is an add-on therapy. It can be given in asymptomatic siblings. Asymptomatic sibling. Okay. So this is all about Wilson's disease. This is all about Wilson's disease. And one more question they will ask you. So one more question they will ask you. And then serum ceruloplasmin I left na. Serum ceruloplasmin less than 50 milligram per deciliter. Remember, after treatment, KF ring will disappear. That's all. KF ring will disappear. So this is all about Wilson's disease. Right? So one book said that the only liver issue that cannot occur in Wilson's disease is neonatal cholestasis. So all things are discussed. Serum ceruloplasmin, 24-hour, you will know zinc. Okay, all points are over. KF ring usually disappears after treatment. Okay. So we had covered neonatal cholestasis. We had covered Wilson's disease. Now what is called extrahepatic, and then next thing is extrahepatic portal venous obstruction. You all know that portal hypertension in adults is mainly due to cirrhosis. Either it is due to chronic hepatitis B, hepatitis C, or alcohol induced. But in children, portal hypertension is usually due to prehepatic. as a result of which liver is usually normal. And since liver is normal, synthetic functions will be retained, so they are usually non-sick children. In India, most common cause for portal hypertension is extrahepatic portal venous obstruction. The normal portal venous pressure is less than 10. If it is more than 12, we will call it as increased portal pressure. Usually, your portal vein, okay, splenic vein, superior mesenteric vein, and the splenic vein all together forms the portal vein. Obstruction can occur in superior mesenteric vein or splenic vein, sometimes in the portal vein itself. Portal vein itself. One of the most common um, causes for this obstruction is one is cavernous malformation of the portal vein, or it can be due to umbilical catheterization that you do when the child is in the neonatal period. You all know that portal hypertension always leads to esophageal varices. Sometimes you cannot get the reason for portal hypertension too. Right? What are all whenever you have portal hypertension? So what is the most common presentation is splenomegaly along with hematomesis. Remember here caput medusa is usually absent in case of extrahepatic portal venous obstruction. I repeat, caput medusa around the umbilicus is usually absent in case of portal hypertension. The complications, as you all know, venous varices around the esophagus, stomach, and in the rectum. Very rarely you will get metabolic encephalopathy. More the splenomegaly, more chances for pancytopenia. More chances for pancytopenia. So this is all about extrahepatic portal venous obstruction. So in this session we had completed Wilson's disease, neonatal cholestasis, extrahepatic portal hypertension. So let's go to the next topic in G8. Okay, next topic in G8, right? So one second, let me transfer it to the team. One second. So first topic we had sent to the corresponding team. So the next one. So what is the next one? There are many topics we are going to discuss in this next one. So what are all the topics we are going to discuss? Acute diarrhea, GERD, Hirschsprung's disease, achalasia cardia, intussusception. So the first one is acute diarrhea, right? So what do you mean by acute diarrhea? Acute diarrhea means the diarrhea that lasts for less than 14 days. Less than 14 days. Acute diarrhea usually resolves within 14 days. In fact, it resolves within 7 days. Persistent diarrhea means non-infective. Sorry. Persistent diarrhea means one lasts for more than 14 days due to post-infectious lactose intolerance. Infectious lactose intolerance. Because of most common, you know, rotavirus. Most common is rotavirus. Most common is rotavirus. Okay. What will happen in persistent diarrhea? Because of diarrhea, the lactase bread brush border enzymes will be peeled off from the mucosa and it is wasted in the stool. So whenever you give milk, it will lead to indigestion of the milk because it is not absorbed by the intestinal lumen, leading to diarrhea. Leading to diarrhea. Okay. So leading to diarrhea. So what is the most common cause? Rotavirus. Most common cause for blood in stools in pediatrics is infective cause is Shigella dysentery. Is Shigella dysentery. So diarrhea following broad spectrum antibiotics can be due to Clostridium difficile, but I have not seen this antibiotic induced Clostridium difficile type of diarrhea to my knowledge. Okay, so what happens in case of, so whenever any child is brought with diarrhea, whenever any child is brought with diarrhea, whenever any child is brought with diarrhea, right, can be classified based on the amount of the water loss from the body. The dehydration can be classified. So how clinically we can identify whether the child is having no dehydration, sub-dehydration or severe dehydration because of diarrhea? The answer is very simple. In case of no dehydration means the child will be playful. Eyes not sunken. Tears will be present. Tongue will be wet. There will be no abnormal thirst. Skin pinch goes back quickly. Treatment homemade foods. ORS 10 ml per kg per stool. This is the treatment for some dehydration in which less than 10% of dehydration luck. For no dehydration. No dehydration. What is some dehydration? Here the child is irritable. Here the child is irritable. Eyes are sunken. Tears will be reduced. Tongue will be dry. Thirst will be drinks eagerly. Skin pinch goes back slowly. More than 1 second. More than 1 second. Okay, skin pinch goes back slowly more than 1 second. What is the treatment? ORS 70 ml per kg over 4 hours. Over 4 hours. What is called severe dehydration? In severe dehydration, the child will be lethargic. There are eyes will be very sunken. Tears again are absent. Thirst will be the child cannot able to drink, can't drink even when you give. Thirst absent, can't drink anything. Skin pinch goes back very slowly, takes more than 2 seconds to dissolve. What is the treatment for severe dehydration? In a child less than one year, 30 ml per kg of RL over 1 hour, followed by 70 ml per kg over 5 hours. Whereas in case of children more than 1 year, severe dehydration can be corrected rapidly. So that 30 ml per kg can be given over half an hour and 70 ml per kg can be given over 2.5 hours. So you can do correction within 3 hours. Unlike in children less than 1 year in which you need to give for over Correction should be over 6 hours. This is important. This is important. Right now. So this classification is very, very important. This treatment is very, very important. What are all the indications for antibiotic? Let me see. Now, then this point is very, 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 very important. It's called ORS, rehydration solution for what is ORS? ORS is nothing but oral rehydration solution. One second. Initially, diarrhea was mainly due to cholera, in which the osmolality load in the stool is much, as a result of which the old ORS was designed with an osmolality of 311. Okay, 311 with glucose concentration of 111, sodium 90, chloride 80, potassium 20, citrate 10. This is standard ORS meant for cholera. Then we understood the fact that majority of diarrhea is due to rotavirus, in which the osmotic load of stool is not that to the extent caused by cholera. So the osmolality of ORS has been reduced from 311 to 245. Sodium concentration is reduced from 90 to 75. 90 to 75. Glucose concentration has been reduced from 111 to 75. Whereas chloride more or less same, potassium more or less same, citrate more or less same. Whereas what is called rhizomol? Rhizomol is rehydration solution for severely malnourished children, in which there will be chronic hypokalemia, and because of hypotension, the child will be having renin angiotensin mediated hypernatremia or normonatremia, as a result of which the sodium concentration will be high or low, high, normal, or high. So, but because of chronic, what is that? Because of chronic fecal loss in malnourished children, you have hypokalemia. So what happens? Sodium concentration should be decreased from 75 to 45, and your potassium concentration should be increased from 20 to 40. Malnourished children are prone for hypoglycemia, so your glucose concentration has been increased from 111 to 125, and your total osmolality is around 300 milliosmol per kilogram. This chart is very, 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 very important. The composition of various ORS solution. Composition of various ORS solutions. Solution. The only treatment indicated for acute diarrhea is zinc. How much you need to give? Zinc should be given 20 milligram per day for about 14 days. Okay, for children 20 milligram per day for about 14 days. For persistent vomiting, you can give ondansetron. Whenever a child with loose stools presents with abdominal distension and sluggish bowel sounds, it is due to hypokalemia. Hypokalemia, main cause. Whenever you have convulsions in diarrhea, it can be due to Shigella encephalopathy. It can be due to hypernatremia. It can be due to hyponatremia, or it can be associated with fever-induced febrile convulsions, or because of dehydration leading to thrombosis, where cerebral venous thrombosis. Cerebral venous thrombosis. Okay. Okay, cerebral venous thrombosis. Right. So this is all about diarrhea. Very, very important question is whenever you have convulsions in diarrhea, think about the following things: Shigella encephalopathy, febrile convulsion, hypernatremia, cerebral venous thrombosis, and hyponatremia also. Antimicrobials. Doxy in case of suspected cholera. How much? 2 mg per kg per day stat dose. And blood in stools, for which you can give cefixime. Blood in stools. 10 mg per kg per day. These are all the two antibiotics. Suspected rice water stools or blood in diarrhea. Rest of the things you do not require. Okay, you do not require. Then acute diarrhea, other drugs. Acute diarrhea, other drugs. Please do not use loperamide, anti-motility drugs. It will lead to ileus. Pectin, kaolin, bismuth we don't use. Rasigodotril, no proven rule. No proven rule. Lactobacillus rhamnosus reduces diarrhea by about 1 day. Reduces diarrhea by about 1 day. Reduces diarrhea by about 1 day. Okay. 1 second. Reduces diarrhea about 1 day. Right? 1 day. Right. So, what about dysentery? Once again, excuse me. Book it. List. Sorry. Okay. So what about dysentery? Any child with persistent abdominal pain and blood in stools, instead of thinking about Shigella and then entamoeba, think about intussusception first. Think about intussusception first. Most common in India is Shigella dysentery. Dysentery is the most common cause. Most common abroad. Okay. In pediatrics, your enter in pediatrics, entamoeba is very, very rare. In pediatrics, entamoeba is very, very rare. Amoeba is very, very rare in pediatrics. Pediatrics. Most common cause for again outbreaks is Shigella. The most common complication associated with Shigella is encephalopathy. Febrile convulsions you can have. Okay, what is the drug of choice? Drug of choice is cefixime. Unstable patient who cannot take tablet orally is ceftriaxone. Okay, ceftriaxone. Okay, right, ceftriaxone. Right, so this is about drugs that we use in diarrhea. Diarrhea lasting for more than 14 days post-infective due to lactase deficiency and due to lactose intolerance. Lactase deficiency and lactose intolerance is persistent diarrhea, whereas chronic diarrhea is non-infective. Chronic diarrhea is non-infective. Chronic diarrhea is non-infective. The causes are: one is celiac disease, Second one is cow milk protein intolerance. These two are more than enough for you. So less than 2 years, cow milk protein intolerance. More than 2 years, celiac disease. Celiac disease. Okay, one second. One second. Okay, less than 2 years, more than 2 years. When to consider secondary lactose intolerance? When diarrhea lasting for more than 14 days, it is frothy stools, more than 14 days, frothy stools, and you have perianal excoriation. Perianal excoriation. More than 14 days, frothy stools, perianal excoriation. Okay, this is called, and you have, okay, frothy stools due to gas formation. The unabsorbed lactose is fermented by the colonic bacteria. These are all the things you need to consider. Secondary lactose intolerance. Okay. So what is called in case of persistent diarrhea, what you need to do? Treatment. The treatment for persistent diarrhea is, this question will be asked. Diet A, Diet B, Diet C plan. Okay. So what is Diet A plan? Diet A plan is low lactose diet. Cereals can be given. Whereas what is Diet B plan? Diet B plan is no lactose. Cereals can be given. What is Diet C plan? Diet C plan is no lactose diet, no carbohydrate diet, only glucose, solution, chicken, and then egg. And this is called as monosaccharide based diet. This is called monosaccharide based diet. Called monosaccharide based diet. So what is the role of unripe green banana in persistent diarrhea? So it adds short chain fatty acids for the intestinal bacteria. Okay, intestinal bacteria. Right. So now what are all the things they will ask in diarrhea? So let me summarize. What are all the things? So one is, what are all the things they will ask you, as I told you already? So dehydration classification they will ask you. No, some severe. What are all the different types of ORS they will ask you? What is persistent diarrhea they will ask you? They can also ask you what is diet A, B, C plan. Diet A plan is no lactose diet. Diet B plan is lactose free diet. Diet C plan is monosaccharide based diet. Monosaccharide based diet. Okay, monosaccharide based diet. Dehydration, ORS, persistent diarrhea, diet A, diet B, diet C plan. And then when you will use antibiotics in diarrhea. So these are all the things that we have discussed so far. And what do you mean by dysentery? And what are all the drugs we use in dysentery? The drugs that we use in dysentery are cefixime in stable patient, ceftriaxone in unstable, That's all. Cefixime in stable patient and ceftriaxone in unstable patient. Okay, right. So these are all the things that we had discussed so far in case of diarrhea. Now, so diarrhea is over. Now let's come to the next topic. 3-week-old boy present with persistent non-bilious vomiting and failure to thrive. So what is the answer? The answer is hypertrophic pyloric stenosis. Non-bilious vomiting boy fourth week is hypertrophic pyloric stenosis. What is the electrolytic disturbances? It is hyponatremic, hypochloremic, hypochloremic, metabolic alkalosis with paradoxical aciduria. With paradoxic aciduria. Most common sign is there are many other findings for hypertrophic pyloric stenosis. One is non-bilious vomiting. A child presented with non-bilious vomiting, visible gastric peristalsis, palpable olive-shaped mass, and then you have dyselectrolemia. Dyselectrolemia. Okay, visible gastric peristalsis, olive-shaped mass, and then dyselectrolemia. But what is the most pathognomonic is? Most pathognomonic is olive-shaped mass. Most pathognomonic is olive-shaped mass. Shaped mass. Okay. So what is the investigation of choice? Investigation of choice is ultrasound abdomen. Abdomen. In ultrasound abdomen, if the length, okay, in ultrasound abdomen, okay, they will find out the thickness and the length of pyloric sphincter. Length of pyloric sphincter. And the length of pyloric sphincter. Okay, ultrasound. In barium swallow, and also in barium swallow, you will have single bubble appear. Single bubble appearance in barium swallow. So what is the investigation ultrasound? What is the treatment? Treatment is Ramstead pyloromyotomy. For emergency, you can give atropine, which reduces pyloric spasm. Which reduces pyloric spasm. Okay, this is about hypertrophic pyloric stenosis. What is this? Spasmodic torsional dystonia with arching of back and opistotonic posturing. So this is called as Sandifer syndrome. This is called as Sandifer syndrome due to gastroesophageal reflux disease. What is that called as? Sandifer syndrome. Short question they will ask you. Sandifer syndrome. Okay, what is the treatment of choice? Proton pump. What are all the proton pump inhibitor? Lansoprazole, omeprazole, esomeprazole, etc. Okay, for 2 weeks. Okay, for 2 weeks. So this is for GRD. Then let's go to the next question. So look at this. The child is significant failure to thrive. Infant with vomiting, regurgitation, and failure to thrive. There is something in barium swallow. The child is having failure to thrive. What is that? Yes, this is achalasia cardia. So look at this. Dilated esophagus. This is called achalasia. This is called achalasia. Okay. Achalasia cardia, in which lower esophageal sphincter fails to relax. Lower esophageal sphincter fails to relax because of low nitric oxide. Okay, what is the low? Okay, lower esophageal fails to relax because of. So, what is the investigation in barium swallow? The by in barium swallow, you will have dilated esophagus. Esophagus. Okay, right. So, surgical treatment is available. In adults, people can use botulinum toxin. In pediatrics, it is not that much. Which one? Botulinum. So, achalasia cardia should be suspected when the child is having dysphagia for liquid fits. Dysphagia for liquid fits. Because achalasia cardia is a motility disorder. Achalasia cardia is a motility disorder. So, this is all about achalasia cardia. And then, so you see this. Achalasia. Okay, right. Now, what is called Hirschsprung's disease? Whenever, so when will you suspect Hirschsprung's disease? When will you suspect Hirschsprung's disease? Hirschsprung's disease should be suspected when any infant develop constipation, even during the time when the child is on breastfeed. A breastfeeding child will never get constipated. Whenever you see constipation in a breastfeeding child, that too in the first 6 months of age, you need to suspect Hirschsprung's disease. You all know that meconium should be passed within. You all know that. Okay, you all know that what happened. Okay, so what is Hirschsprung's disease? Hirschsprung's disease should be suspected in all infants who develops constipation less than 6 months. Delayed passage of meconium. Delayed passage of meconium. What do you mean by this? Delayed net earlier. So, delayed passage of, that is, child fails to pass within 2 days after birth. Right. Okay. So delayed passage of meconium. Meconium fails to pass within 2 days. Suspect. So it is the commonest motility disorder in which there will be no enteric nervous system. No enteric nervous system development. It is a disease involving neural crest cells. Neural crest cells fails to migrate. Fails to migrate. Neural crest cells fails to migrate. Okay. So what is the pathology? Fails to migrate. What is the pathology? The pathology is usually hypertrophied nerve fibers. Hypertrophied nerve fibers. Nerve fibers and aganglionic cells in the intestinal biopsy. In the intestinal biopsy. Remember, this is often associated with growth failure, whereas functional constipation, which occurs as a result of uh, giving food that is not good in fibers, often leads to constipation, but growth failure will not be there. Remember, in Hirschsprung's disease, because of chronic constipation, intestinal bacteria proliferates. Intestinal bacteria proliferates. This proliferated bacteria, which in turn calls enterocolitis, which in turn leads to enterocolitis. Colitis. And remember, in Hirschsprung's disease, because of severe constipation, the liquid that is present above the level of the stool will dribble, okay, around the fecal pellets, and it comes at around soaks the perianal area, leading to encoparesis. Okay, leading to encoparesis. Encoparesis is a feature more of a constipation, habitual constipation rather than Hirschsprung's disease. Okay, most common association is neurofibroma is an association. Hirschsprung's disease. Okay, right. What about perectal examination? Perectal examination is usually empty in case of Hirschsprung's disease. Okay, your rectum is empty so that your rectosigmoid ratio, okay, will be less. Confirmatory test is biopsy. Gold standard is rectal manometry. Is rectal manometry. Gold standard is rectal manometry. Okay, right. So this is, and then what is the treatment? The treatment of choice for Hirschsprung disease is resection and end-to-end anesthesia. Single stage resection and end-to-end anastomosis. Okay, for Hirschsprung's disease, right? And other things that they can ask you is, what is the difference between, I'm sorry, what is the difference between habitual constipation and Hirschsprung's disease? What is the difference between habitual constipation and Hirschsprung's disease? So remember, habitual constipation, less than 6 months. I'm sorry, more than 6 months. Habitual constipation is usually more than 6 months. One, due to poor fibers in the diet, no failure to thrive, no failure to thrive. Okay, no failure to thrive. Second point, okay, your rectum will be loaded with colon. Rectum will be loaded with colon. Next point is, you can have encoparesis. That is a leakage of the liquid part of the stool. And finally, anorectal inhibitory reflex is intact. Reflex is intact. That means when you stimulate the anus, the lower rectal sphincter will release. That happens in case of habitual constipation. Whereas in case of Hirschsprung's disease, it usually occurs less than 6 months. The problem is neural crest fails to migrate. Failure to thrive will be present. Rectum loaded with colon, here rectum will be empty. Encoparesis you won't see. Anorectal inhibitory reflex absent. Okay, these are all the differences between habitual constipation and Hirschsprung's disease. Okay, now what is intussusception? Remember, when any child is brought with incessant cry, incessant cry, often cry with colicky pain, At times you can have vomiting. At times you can have red currant jelly. Stools. It can be due to intussusception. Incessant cry colicky, pain, vomiting, red currant jelly stools. Is intussusception unless otherwise proved. Blood in stools after 6 months is the most common manifestation. Why it occurs? Due to air patch hypertrophy. Due to air hypertrophy. Okay. Usually occurs between 6 months to 2 years. 2 years. The lead point is air patch hypertrophy. Okay. Air patch hypertrophy. Right. So you have two things. So in intussusception, so one segment of intestine goes into the another part and it causes obstruction. So less than 2 years, almost always due to pair patch hypertrophy. And it is usually ileocolic. It is usually ileocolic intussusception. But more than 2 years, often it is pathognomonic. It can be due to a neurofibroma, can be due to an hemangioma. It can be due to a polyp. It can be due to a polyp. A polyp can cause, which can act as a, it can also be due to a tumor. All can cause a leading point. And it is usually ileal or colocolic and usually occurs more than 2 years. So more than 2 years, ileocolic or colocolic, ileal or colocolic means always rule out some structural pathology inside. Even your vasculitis such as HSP can produce it. What is there in plain X-ray? You can have claw sign. What is there in USG? You can see donut sign. Usual treatment of choice is barium minima reduction. If it recurs, you can do surgical reduction. Surgical reduction. So, what are all the things we had discussed so far? Hirschsprung's disease. We have discussed about Hirschsprung's disease. We have discussed about achalasia cardia. Okay, we have discussed about intussusception. Okay, diarrhea, ORS, etc. Okay, ORS, etc. So this part is over. Wait, let me transfer it now itself. Let me transfer this one. Wait. Transfer. Now some other topics. What are all the other topics that you need to cover? Let me other topics. What are all the other topics? One second. So now let us complete some of the topics on inherited hyperbilirubinemia. Inherited hyperbilirubinemia. Remember, in case of Gilbert syndrome and Crigler-Najjar syndrome, they are usually due to indirect hyperbilirubinemia. Whereas Dubin-Johnson syndrome and Rota syndrome are direct hyperbilirubinemia. Gilbert syndrome is due to deficiency of glucuronide transfer. Deficiency of glucuronide transfer. And majority, even I have one child with Gilbert syndrome. Usually, whenever fever, cough, cold comes, she used to come with jaundice. Without any treatment, it resolves on its own. So it can come as a recurrent jaundice precipitated by illness and vomiting. No treatment is often necessary. Okay. What about Crigler-Najjar syndrome? Crigler-Najjar syndrome is characterized by type 1, type 2. Type 1 total absence of UDP glucuronide transferase, in which there will be severe indirect hyperbilirubinemia leading to kernicterus, and the child often needs either exchange therapy or plasmapheresis, and you need to go for liver transplant. Whereas in case of Crigler-Najjar 2, there will be little bit of reduction of glucuronide transferase. So you can give phenobarbital, which can increase glucuronide conjugate. And this is not associated with kernicterus and it is less severe. So Gilbert syndrome, recurrent jaundice, Crigler-Najjar syndrome, persistent severe jaundice. What is Dubin-Johnson syndrome and Rotar syndrome? Dubin-Johnson syndrome and Rotar syndrome are characterized by increase in direct bilirubin. Are characterized by increase in direct bilirubin. So in Dubin-Johnson syndrome, there is one peculiar thing. You have brown-black pigmentation in liver biopsy. Okay, often they have normal LFT. Okay, conjugated jaundice, other things are normal. Impaired hepatic excretion of bilirubin. Whereas Rotor syndrome is characterized by, okay, reduced intracellular storage capacity, liver for binding anions. And this is characterized by normal histology without any black pigmentation, and it is associated with mild conjugated jaundice. So Gilbert syndrome, Crigler-Najjar syndrome type 1 and 2, Dubin-Johnson syndrome and Rotar syndrome are must you need to know, right? Need to. Then the next thing that you need to know is, what is that? Hepatic encephalopathy, which was missed. What are all the stages for hepatic encephalopathy? The stages for hepatic encephalopathy are 4. Stage 1, 2, 3. The most common cause for acute hepatic failure in pediatrics is paracetamol poison. Is paracetamol. Why is it so? Because people used to, you have drops. Drops contain 1 ml equal to 100 milligram. Syrup usually contains 5 ml equal to 120 milligram. So 1 ml equal to 20 milligram. What happens when fever doesn't subside? People used to give drops thinking that it is a syrup. And they will give syrup dosage of 5 ml. 5 ml. They will give syrup dosage of drops as 5 ml. So 5 ml contains 500 milligram. Once or twice it is okay. But more than that, it can lead to acute hepatic failure. Initially, hepatic encephalopathy, the first manifestation is altered sleep-wake cycle. That means morning he will sleep, evening he will be awake. Along with that, trouble drawing pictures. Performing mental activity will be tasks that require mental activity cannot be done properly. Okay, reflexes are usually normal. EEG is Whereas when it goes to stage 2, here comes the abnormal fetal hepaticus water due to ammonia, and there will be disoriented and agitated, and they will have behavioral disturbance. Okay, and here comes asterixis. Here comes asterixis hyperreflexia, and this is often characterized by generalized abnormal slow wave EG. Stage 3 is confused incoherent speech. Here the child is hyperreflexic, asterix present, extensor reflexes, rigidity and conus, along with the triphasic waves in each. Whereas stage 4 is characterized by coma. Characterized by coma. It is totally the child will be paralyzed, flaccid, and there will be areflexia instead of hyperreflex. And you have electrocortical silence, that is presence of T waves. Presence of T waves. So this is about the left out neonatal hepatitis. Left out neonatal hepatitis. And the last but not least, let me cover immunization schedule if it is not covered. So very, very important. Immunization. Okay, at birth, will give BCG, OPV, hepatitis B. At 6 weeks and 14 weeks, 6 and 14 weeks, you give OPV, you give rota, you give pentavalent. At 6 weeks and you give intradermal IPV. You give PCV 10 and PCV. So 1 3 1 3 1 3 1. This is 6 weeks and 14 weeks. At 10th week, at 10th week, why I had given 6 weeks and 14 weeks together? Because it is one and the same. At 10th week, OPV, yes. Rota 2, yes. Pentavalent 2, yes. But IPV, no. PCV, no. At 10th. And then at 9 to 12 months. 9 to 12 months. At 9 to 12 months, will give Japanese encephalitis 1, measles rubella 1, IPV booster dose, PCV, IPV booster dose, PCV booster dose. Okay, PCV booster dose at 9 to 12. At 15 to 18 months. At 15 to 18 months. At 15 to 18 months. DPT MR2 JE2 and then OPV boost. At 5 years, you give DP. At 10 years, you give T. So this is the vaccination schedule. The new Indian immunization. Okay, immunization, right? Station schedule. Okay, new immunization schedule over. What are all the vaccines that are kept in vaccines that are kept in freezer? Mainly OPV. Vaccines that are kept in row below freezer. First rank BCG, MMR or MR. What is the vaccine that is kept in middle compartment? You have PCV, you have PCV, you have hepatitis A, you have PCV, hepatitis A, middle compartment. You have DPT, PT, PD. All vaccines are kept in second middle compartment, lower compartment is you keep diluents, varicella, hepatitis. Nothing. What are all things you need to keep in store? No, should be kept in store. Right. What are all the diluents you know? Majority of them uses sterile water, but some you use normal, mainly for BCG and yellow fever. For BCG and yellow fever. This is for vaccine, BCG and yellow. Then comes what are all the oral vaccines? Oral vaccines are OPV. What are intradermal vaccines? IPV, rabies, and then BCG. What are subcutaneous? Subcutaneous means live vaccines. Measles, rubella, hepatitis B. Measles, rubella, hepatitis A, live vaccine. Hepatitis A, then varicella. Subcutaneous. Intramuscular, toxoids, PCV, PD, PT, EPT are given intramuscular. Finally, what do you mean by catch-up vaccine? Catch-up. Whenever any child who doesn't take any vaccine and comes to you after the stipulated time got over means catch-up vaccine. How do you vaccinate the child? So less than 7 years. So on the day you see the next month, second month, and then sixth month. So 016 you need to give DPT along with hepatitis B, hepatitis. Less than 5 year, 1 year means you can give PC. Less than 1 year. Okay, you can give BCG. At second month, you can give typhoid and then measles. Whereas more than 7 years, at the first dose, TD, TDAP, TDAP, first month TD, second, sixth month, along with hepatitis B, hepatitis B, hepatitis B, 016. As usual, at second month, you can give typhoid conjugate vaccine. Okay. So with this, we are finishing our discussion for a series. Thanks for your patience.